Good afternoon. We're going to go ahead and get started with our Health Committee hearing this afternoon. Got a couple of announcements. First of all, on today's issues, we will hear two witnesses per side with a time limit of 3 minutes each. We have over 30 bills today, and so it's important that we really try to do our best to adhere to that. Additional witnesses will be asked to please only state the name and organization for the record and your position on the measure. At the request of the author, I'm allowing, although she isn't here yet, Assemblymember Melendez to take up item number 15 AB 2255, and then immediately following we will hear item number 6 by AB 2002 by Assemblymember Bloom. We have several bills proposed for the consent calendar today. Item number 12, AB 2207, Wood with amendments. Item number 16, 2325, Bonilla. Item number 24, 2589, Gomez with amendments. Item 26, AB 2670, Hernandez, Roger. Item number 27, AB 2750, Gomez. And a Health Committee bill, AB 2889. Item number 34, AB 2725, failed passage last week and was granted reconsideration. It's up for a vote only. The author has accepted the committee's recommended amendments. Seeing we do have an author present, and I don't see Ms. Melendez. So, Mr. Gibson, are you ready to proceed? Please come on. You've got a couple of bills before us today. Please proceed when you're ready, Mr. Gibson.
Okay. Thank you very much. Good afternoon, Mr. Chair and members. Let me thank you for allowing me to present Assembly Bill 1763, which seeks to improve access. I'm taking Assembly Bill 1763, by the way, okay, which seeks to improve access to care by removing cost barriers to colonoscopies for adults ages 50 to 75 in high-risk individuals. Colon cancer is the second leading cause of cancer death in the United States and the third most common cause of death in men and women. Colon cancer is preventable, treatable, and beatable disease, but only with proper screening. Standard screening for colorectal cancer includes stool blood tests and a colonoscopy. Many individuals opt for the simpler one, non-invasive stool blood tests, as their choice for screening. However, if that initial test comes back positive, a follow-up colonoscopy is required. The average cost of colonoscopies is $913, and this cost can create a barrier for many individuals. AB 1763 seeks to remove that barrier by eliminating the cost sharing for colonoscopies, increasing access to screening for colorectal cancer will catch cases of cancer sooner and improve long health outcomes. It is essential that we improve patients' equal access to all screening options necessary to achieve the highest screening rate, which can be accomplished by removing cost barriers to screening. Here with me to provide supporting testimonies are individuals from organizations such as the American Cancer Society, Action Network, and the California Colorectal Cancer Coalition, who will self-introduce.
Good afternoon, Chair and members. Autumn Ogden with the American Cancer Society Cancer Action Network. Here's a proud co-sponsor of AB 1763. Under the ACA guidelines, that requires that all private insurers cover preventative services that receive an A or B rating from the United States Preventative Services Task Force, or USPSTF, without any patient cost sharing. The USPSTF is an independent volunteer panel of national experts in prevention, evidence-based medicine, and primary care that provide evidence-based recommendations about clinical preventative services. The USPSTF has assigned colorectal cancer screenings in this bill with an A rating. The high-sensitivity FOBT and FIT tests are effective, non-invasive screenings that are more cost-efficient than colonoscopies. However, a positive result does require a follow-up colonoscopy to be provided. The USPSTF colorectal cancer screening guidelines specifically state that follow-up of positive screening test results requires a colonoscopy regardless of the screening test to be used in order to be considered a full screening. As such, the colorectal cancer screening is not complete until patients with positive results receive that follow-up to rule out the presence of cancer or precancerous polyps. ACS CAN advocates for evidence-based screenings that help reduce cancer incidence and mortality. The overall reduction of colorectal cancer incidence and mortality rates in the U.S. over the last few years has largely been attributed to increased uptake in preventative screenings. Eliminating out-of-pocket cost sharing for follow-up colonoscopy after a positive stool test will eliminate a significant barrier to colorectal cancer screening, and for these reasons, I respectfully ask for your aye vote today.
Thank you.
Good afternoon, Chair and members. I'm Dr. Daniel S. Anderson. I'm the President of the Board of the California Colorectal Cancer Coalition. I'm a proud co-sponsor of this bill. It will help us achieve our mission to reduce deaths and reduce suffering from colorectal cancer in all Californians. In 2012, from the California Cancer Registry, about over 14,000 people developed colon cancer, and about over 5,000 died of colon cancer in 2012. This is a true tragedy since colon cancer is so preventable. It has the most effective colon cancer screening tests of any cancer screening test. Unscreened, you have about a 6.7% chance of getting colon cancer. That's 1 in 15. So not quite one on your committee would get colon cancer in their lifetime unscreened. So I encourage you when you reach age 50 to get screened for sure. About 2.8% will die of colon cancer, about 1 in 35 if they're unscreened. With screening, colon cancers are prevented in two ways. First, all of the screening tests find polyps. The polyps can be removed, the cancer can be prevented, and all the screening tests shift the stage of the cancer towards the more early treatable cancers. So, with screening, the colon cancer mortality drops from 2.8%, 1 in 35, to 0.5%, 1 in 200. That's an 80% effectiveness for screening. And these are from the mathematical models in the U.S. Preventive Services Task Force draft guidelines. So the message for you is that we only have to screen 50 people to save one person from dying from colon cancer. In spite of this incredibly effective screening through the FIT test every year or colonoscopy every 10 years, only 67% of Californians are screened. It is important for you to know that the screening tests are equivalent. There is no best screening test. The best screening test is a test that gets done. So why are so many Californians unscreened? We know from numerous studies that we have to offer both the colonoscopy and the fecal test to the population to achieve the highest screening rates. We must be sure that the FIT test does not put a financial burden on the patient, because we know if there's a financial burden on patients for screening tests, it reduces the screening rate. When the financial burden is removed, the screening rate goes up, and that affects most of the low-income people. I know you're concerned about the costs. I encourage you to go to page 24 of the California Health Benefits Review And they said some of the model-based studies have found that colorectal cancer can become cost-saving in the long run. The FIT testing, the more it's done, and that's the one this bill affects, you can put $191 back into the healthcare system. So by voting for this bill, you will increase colon cancer screening rates and save lives. With the increased use of the FIT test, we can put money back into our healthcare system. I'm begging for your yes vote on this bill. Help save lives and reduce suffering from colon cancer. Thank you very much.
Very good. Thank you very much. Witnesses to support, name, organization only, please.
Kat DeBerg with the Health Officers Association of California in support.
Great. Thank you.
Greg Herner on behalf of the California Life Sciences Association in support.
Jasmine Gordon on behalf of the California Black Health Network in support.
Thank you.
Teresa Anderson with California Academy of PAs. We want to thank the author and sponsors for working with us to address concerns and bring us to a support position.
Thank you. Any opposition? People speaking in opposition, please come forward. I will note also that we are starting as a subcommittee. We do not have a quorum, so we won't be able to take a motion on this until we have a quorum. And trust me, I'll be keeping my eyes open, counting. There's 18 of us, and, well, you're only seeing 6, so 5. I can't even count. So anyway, we'll get there.
Good afternoon, Chair, members of the committee. My name is Jennifer Alley, and I'm with the California Association of Health Plans. We represent 48 public and private organizations that collectively provide coverage to more than 25 million Californians. We oppose this bill that adds new screening requirements on health plans. This bill will result in an increase in premiums. An independent analysis by the California Health Benefits Review Program estimates that this bill will increase premiums by as much as $26 million. We appreciate the opportunity today to talk to you about this mandate and all the other mandates that we will be going through on this agenda. The cumulative cost of the mandates is roughly $125 million to $430 million in total premium increases. CAP members currently provide colorectal cancer screening as required as an essential health benefit. All screening requirements in the ACA were initially linked to the United States Preventative Services Task Force recommendations. This task force is currently reviewing colorectal cancer screening procedures and requirements, and we anticipate new guidelines to be issued later this year, making this bill premature. While we appreciate the efforts of the author and sponsors to address some of our initial concerns with an earlier version of the bill, we cannot remove our opposition at this time. The amendments made for the screening requirements do not mirror what is currently in the United States Preventative Task Force recommendations. This bill prescribes a colonoscopy with polyp removal to be used after the age of 50 with no cost sharing. My members report that the use of a specific age is problematic because they don't differentiate cost savings based on an enrollee's age. In addition, this type of procedure is not recommended for an individual over the age of 75. There's no cap on the screening requirement currently in the bill. So again, this is just the wrong time to pass new mandates. Thank you.
Thank you.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. Regrettably, we are here too in opposition. We'd like to thank the author and the sponsors. We have worked with them collectively on some of the amendments. Unfortunately, they don't remove our entire opposition. We do think that there are some concerns that there's no currently a definition for high risk in the bill. We'd like to point to CMS does have a definition that we'd like to continue to work with the author and the sponsors to see if we can clarify that. Additionally, on the no cost share issue, I think it should be noted that that is determined by the provider when they code the diagnostic screening. So to the degree that we can continue in a collaborative effort, we're open to an open dialogue, but unfortunately, as the bill is here today, we do see it as a mandate, and it would increase pressure on cost as well as affordability. So for those reasons, we remain opposed. Thank you.
Great, thank you. Others in opposition?
Yeah, John Winger on behalf of America's Health Insurance Plans, also opposed.
Okay, thank you.
Allison Ramey with Blue Shield of California in opposition.
Thank you.
Sherry McHugh representing the California Chamber of Commerce. We are in opposition, but we look forward to continuing to work with the author on future amendments. Thank you.
Great, thank you. Back to the committee. Questions or comments? Mr. Mainsheim.
Thank you very much, Mr. Chairman. And I just wanted to say a few words kind of in interest of time. I know it's be a very busy hearing. First, I am going to support this bill. but I did want to make a comment about something that I think is important for our committee. We are going to be hearing a number of mandate bills that will be before us today. Many of these bills, while well-intentioned, contain a cost requirement that alone may not be harmful, but in the aggregate could reach very significant proportions. And these costs will not be covered by federal or state government, but rather will be passed on to ratepayers. So maintaining affordable premiums under the Affordable Care Act is certainly a delicate balancing act. If one side kind of tips out of balance, it puts affordability at risk. And in the recent MCO negotiations, we were very careful to ensure that it wouldn't have a negative rate or impact on the rates our constituents have to pay for their health care. So I think it would be unfortunate to undo some of that by implementing potentially billions of dollars in new health mandates. And so for these reasons, I think this committee needs to consider, really needs to strongly consider the cumulative impact of these mandates on premiums, particularly as we face the inherent pressures of an evolving market.
And I want to thank my vice chair, Mr. Mainshine, for those comments. And he and I have spoken about this, and I share his concern as we go forward. This could put, in time, could put tremendous pressure on a system that is really at this point getting its legs and hopefully going to be able to stand firmly on its own in the future. But it is a challenge. But as we continue to work with authors on these issues going forward, we're going to have to be mindful of that. Though that being said, and this particular bill, I'm going to be supporting the bill. And I appreciate the spirit in which this is brought forward, and I understand from personal experience with family members the value of being able to remove these polyps at an early stage, and some of which in my own family were cancerous. So that prevention, I believe it's a preventive procedure personally, and that led to a long and healthy life for one of my dearest family members. So I appreciate that, and I understand the challenges. It is going to be a delicate balancing act as we go forward. So I appreciate as we go forward how we deal with this will continue to challenge us for probably years to come. So at this point, are there any other questions or comments, Mr. Thurman?
Thank you, Mr. Chair. I wanted to ask the author or his witness to elaborate on the cost savings that could potentially offset the concerns that we've heard. I want to be mindful of the cost concerns that the chair and vice chair have alluded to, and I respect their consideration. And I may be looking at it too simply and just saying, if anything that we do save lives, that it's worth that cost. But I want to be mindful of it, and I understood one of the witnesses to say today that there could be cost savings, and just would like to hear brief elaboration on that, if that can help to offset the kind of cost pressure that providing expanded service might cause on our systems.
Thank you. Thank you for that question. The people that do the analysis, the financial analysis for the U.S. Preventive Services Task Force, published an article in 2009 in the Journal of National Cancer Institute. And they looked at the cost of screening, and the title of the article was "The Effect of Rising Chemotherapy Costs on the Cost Savings of Colorectal Cancer Screening." And because of the cost of the treatment necessary in advanced stage liver disease, many of which are cured but at great expense, they did their analysis, and they showed if you put a person through a FIT testing, the highly sensitive fecal occult blood testing, you put over time, as that person is screened, $191 back into the healthcare system that you didn't have to spend on chemotherapy costs. They also looked at colonoscopy. It almost was cost saving. It was about $296 per person screened over their lifetime with colonoscopy. So both are by far the most cost efficient, and one, the FIT test, is cost saving. Mm-hmm. And this bill pushes us to use and removes the barriers from doing the FIT testing. It was said that the new U.S. Preventive Services Task Force guidelines are changed. They are not. The only change so far in the draft guidelines is they've moved FlexSig from 5 years to 10 years. The rest are the same 3 tests: FlexSig, highly sensitive fecal occult blood test, and colonoscopy. Nothing else.
Thank you.
Great. Thank you very much. Any other questions or comments? Okay, we'll wait for a quorum, and we'll be able to hopefully take a vote on your measure at that point. So next bill then.
Thank you very much, Mr. Chairman. Also, we want to accept the amendments as
Thank you.
committee
Appreciate
amendments.
you accepting the amendments.
Sure. Thank you very much. So we'll move to AB 2640. Mr. Chair and members, I would like to begin by accepting the amendments offered by the committee and thank the chair and the committee for working with us on this bill. Thank you for allowing me to present Assembly Bill 2640, which seeks to stop the spread of HIV by ensuring patients are more informed about prevention. In 2013, California has a second highest number of new HIV diagnoses among all 50 states. Considering the high volume of the new HIV infections being diagnosed, it is critical that those being tested are aware of preventative medication. AB 2640 will provide those high risk for contracting HIV with a written information about the method that they can lower their risk for contracting this virus, including preventative medication. These medications, known as PrEP and PEP, reduce transmission of HIV and prevent new infections in at risk of HIV negative individuals. PEP has been shown to be up to 80% effective and prevent HIV infections, and PrEP up to 96% effective rate. Current law details what information should be provided to patients after an HIV testing, such as the presence of numerous treatment options and non-medical preventive practices. Now, we need to ensure that the testings are more up-to-date and accurate information on these new modern technologies and medicines are brought to the forefront. Here with me are individuals from LA LGBT Center and also the AIDS Project Los Angeles, who will self-introduce and give supporting testimonies.
Good afternoon. My name is Dr. Robert Boland. I'm the medical director at the Los Angeles LGBT Center and have been involved in HIV work since the beginning of the U.S. epidemic in 1981. I'm here to urge passage of AB 2640, which will require healthcare providers who have just disclosed HIV-negative results to their patients to give them information about FDA-approved methods that can reduce the risk of contracting HIV infection. PEP, as was mentioned, is post-exposure prophylaxis, which is a medication regimen taken within 72 hours of a potential exposure to HIV that can significantly decrease the likelihood of an infection. PrEP is pre-exposure prophylaxis, also a medication which, when taken daily, will prevent HIV infection if an exposure occurs. These protocols are analogous to the so-called morning after pill and birth control pills, respectively, for pregnancy prevention. If a woman comes into your medical office for a pregnancy test and learns, to her relief in this example, that the result was negative, would it be medically responsible to allow her to leave your office without some information about her options for the future? I think not. As you will hear from the next speaker, too many people at risk for HIV and too many providers are not aware of PrEP and PEP. About 13% of those who are infected with HIV in the United States are unaware of their infection. And the CDC estimates that between a third and one-half of new infections in the U.S. are transmitted by these individuals. Further, a substantial proportion of new HIV infections occur within the context of a primary partnership. So both partners outside of a strictly monogamous relationship should know about PrEP. Teachable moments in medicine occur when a patient has experienced a significant and bad health outcome, or has had a scare that their behavior may have caused a health event, but at least this time did not. This is where studies have demonstrated the greatest effect of preventive health education. There are many things that medicine cannot do. We cannot cure the common cold. We cannot cure many cancers. We cannot cure HIV, but we can promote hand washing to prevent cold virus transmission. We can provide assistance in quitting smoking. We can even treat HIV. Medical providers are most effective when they provide information to help engage patients in their own health decisions. Yes, there are many things that doctors are required to do in the very short patient visits. Many have little bearing on quality of care. But to be against providing information about PEP and PrEP to someone who needs it because it adds to a visit is a specious argument. We can help prevent HIV infection by providing information about access to PEP and PrEP. It's the companion to what we must already do following an HIV diagnosis, provide information about treatment of the infection, which is already mandated by California Health and Safety Code. This bill does not mandate detailed conversations. It accomplishes the task of education with a simple card which contains resources for further information. The card is readily available on state and federal websites and is handed out to individuals who have tested negative for HIV. It's a teachable moment. Please pass this bill. It can save lives by reminding medical providers to be the educators we are and tell our patients what we know for sure about what can keep them healthy.
Thank you.
Good afternoon, Mr. Chair and members. Craig Pulsfer from AIDS Project Los Angeles, a proud co-sponsor of this bill. The CDC recently estimated that current HIV infection rates continue. Half of all black gay and bisexual men and a quarter of all Latino gay and bisexual men will be infected with HIV in their lifetime. Passing this bill is a crucial step toward ensuring that these statistics do not become our reality. The introduction of PrEP and increasing availability of PEP mark a turning point in the fight against HIV. These interventions, combined with other proven HIV prevention methods, have given us the tools to finally bring the HIV epidemic to an end. The World Health Organization now recommends that all people at substantial risk for HIV should be offered PrEP. And the CDC recently estimated that reaching national targets for HIV testing and treatment and scaling up the use of PrEP could reduce new HIV infections in the U.S. by as much as 70% by 2020. But we will not reduce new HIV infections in this state unless those at risk are provided with information about how to protect themselves. In 2015, the California HIV/AIDS Research Program surveyed over 600 young gay and bisexual men and found that less than 10% had ever taken PrEP. 85% had never talked to their doctor about PrEP, and black and Latino young men were less likely to be aware of PrEP than their white counterparts. Clearly, information about this revolutionary tool is not reaching those who could benefit from it. This bill is simple. It requires doctors and other healthcare workers to provide written material of their choice to each person who receives a negative HIV test result and is known to be at risk, with accurate information about how to stay HIV negative. Written material containing this information is readily available. For example, Project Inform provides this pamphlet for free to medical providers throughout the state. This bill does not mandate the practice of medicine, nor does it interfere with the doctor-patient relationship. In fact, by encouraging open dialogue between doctors and their patients about sexual health, this bill will strengthen relationships between doctors and their patients. While significant disparities exist, HIV is a disease that knows no color, age, sexual orientation, or gender identity. And if we are truly going to end the spread of HIV in this state, everyone at risk must be empowered with accurate information about all of the preventive options available to them. Thank you.
Thank you very much. Other witnesses in support, just your name and organization, please.
Joe Michael for Equality California in support.
Great, thank you.
Jack Humphrey Straub with the Gender Health Center. We're in strong support.
Thank you.
Robin Learned with the Gender Health Center. We support.
Thank you.
Keiko Torres Oki with the Gender Health Center in support.
Thank you.
Christopher Packey with the Sacramento LGBT Community Center, as well as Strategies for Change Ryan White Program, in support from both.
Great, thanks.
Cynthia Carmona, Community Clinic Association of LA County, in support.
Thank you.
Kathy Mossberg, San Francisco AIDS Foundation, in support.
Great, thanks.
Geraldine Stapleton, California National Organization for Women in Support.
Thank you. Anyone in opposition, please come forward.
Greg Herner on behalf of the California Life Sciences Association in support.
Thank you.
Mr. Chair and members, Rand Martin on behalf of the AIDS Healthcare Foundation. For those who don't know, AHF is the largest nonprofit provider of care and treatment to people with HIV and AIDS in the world. 600,000 patients in 36 countries. We're in 14 states in the United States, in 5 counties in California. This is where we were born. This is where we grew up. We are also the largest private tester in the world, with 4 million tests just last year alone. 55,000 of those were in LA County just this past year. We know testing. We do it. We do it every day. We do it thousands of times every day. We know what works. We were the sponsors of the legislation that created the section that Mr. Gibson seeks to amend today. That section was heavily negotiated in 2008 when advocates wanted to put everything, including the kitchen sink, into the section relative to counseling. It was a bad public health move at that time. The legislature rejected that proposal and moved forward with language that's in the bill that is relatively simple in what has to be shared with the person, assuming that what needs to be shared with an individual is shared at the time that it happens. This section was again heavily negotiated in 2014 in a bill that Senator Mitchell carried. They tried again to put everything, including the kitchen sink, into the bill, and the legislature rejected it. The reason is very simple. The public health implications of HIV and how you convey that to people who are tested changes on a regular basis. Let me give you 2 examples. The first and the most obvious one is if either of those changes were made, especially the one in 2014, to include everything in the counseling section, PrEP would not have been included, and PrEP would have been added in a codification in a subsequent bill. Another good example is that the law relative to the sharing and the use and the purchase of sterile needles has changed repeatedly since 1999 when it was first enacted. If we change in statute what has to be said, it does not anticipate that there will be changes as early as next year that will require additional changes. I recognize that the amendments focus this now on the written word, a pamphlet, which creates even more problems for us because if anybody is, and not to speak ill of my friends at the Department of Public Health, the Department of Public Health is very, very slow at changing written documents. If they have to develop a written information piece that's handed out, I guarantee you by next year it will be out of date, and I guarantee you it will still be handed out. So the information that is relevant today will not be relevant next year. I want to add just one last point relative to PrEP itself. This is not to talk about the medical science relative to PrEP, but the appropriateness in the public health context. If you have a person who tests negative, who happens to be a 45-year-old man who has been married for 20 years, who has a fling and panics and goes and gets tested, and is told by word or by a piece of paper that he should try PrEP, he's going to run off to his doctor and ask to be prescribed Truvada, which means that a man who does not need the pill will be taking it. Truvada does have side effects. It can be toxic, and so you're condemning a person who should not be taking it to forever having to take this pill as long as he wants to be sexually active. We think this is a bad public health measure. We strongly urge you to oppose it. Thank you.
Thank you.
Mr. Chair and members, Stuart Thompson on behalf of the California Medical Association. I first want to thank the author and his staff for continually meeting with us and attempting to work out our issues on this bill. From the Medical Association's perspective, we have our main problem is this is legislating the practice of medicine. Currently, as far as PrEP goes, there's actually only one approved drug that falls into that category, and that's Truvada. Now, Truvada, it is an effective drug. It's been approved by the FDA, but like all drugs, it does have some very serious side effects. And so in this bill, there would be instances where a physician would be required to disclose to a patient information about Truvada, even though that physician may end up recommending against it. Secondly, on the written confirmation piece, on the committee amendments, we do have some concern that not every physician is specialized in HIV and HIV treatment. So leaving it up to the physician to develop the written information to be given to the patient that increases the liability on that physician. And we would like to see that that provision be created by the Department of Public Health, have some standard statewide form that could be distributed for the physicians. Finally, PEP is an emergency drug. It has to be administered within 72 hours of the incident. And in that case, it doesn't seem to make much sense to be required to tell a patient of that when they are HIV negative. Obviously, that drug should only be administered in an emergency situation. And finally, determining whether an individual is high risk for HIV can be a private, and it needs a face-to-face meeting with a physician. Now, HIV tests are given in all sorts of manners. They're given in emergency rooms. They're given in prep for surgery. And in many cases, they're given outside of a primary care context where these questions can actually be asked and it be determined that the individual is actually high risk. And so we do have the concerns on that bill. I know the author has shown a willingness to continue to work towards these issues, but based on the committee amendments, we remain opposed.